found it. There we are.
Good. Yes. Once you click go live, we're all good.
It says you're live. Okay.
Great. So you can just head back to Zoom and enjoy.
Okay. Back to Zoom, which is so. Tom, would you like to take over again? I think that's
Yeah,
how.
sure. And
Stop
and
sharing. Okay. I apologize.
can you see my screen or no?
Yes, I can see it. Can everybody see it? Liz, can you see it? Yes. Okay. Everybody's there.
That's
Okay. I'll do
how.
another introduction for you. Okay. Welcome everybody to this live session on YouTube with Dr. Thomas Wright from St. Louis, Mississippi. We're very, very appreciative of him giving his time this evening to talk to us about his groundbreaking study and how lipedema reduction surgery can really improve people's gait and prevent a lot of knee problems in the future. Over to you, Dr. Wright. Thank you very much.
Thank you so much, Sherry, and it's an honor to speak. And I, of course, this is something I'm passionate about, and I hope my research will help people. So, as Sherry mentioned, this is we noticed. I've noticed everybody knows that the women with lipedema, their mobility or gait can be affected, and this can be quite a problem. And so really this is sort of picking up that. So basically what we looked at is measuring the gait and the mobility parameters. I'm going to get into that before and after surgery. So this was and Dr. Herbst did all the statistics and helped me write this. So I'm very grateful for her help with this paper. So it was published in Plastic and Reconstructive Surgery Global Open. It is available, and I know there's a link to it that you guys shared. It is available to anyone to download the whole paper, and because I'm only going to go over the high points. If anybody who wants to dive deeper, it's there for their study. This was the first study to look at the lipedema reduction surgery in the United States. It's first to document knee joint improvements and gait improvements from the lipedema reduction surgery, and correlate these patient-reported outcomes with objective physical measurements, and the first to show improvement in mobility that correlates with future disability and life expectancy. And so the measurements we used are commonly used in orthopedic literature, and so that they're both the mobility and the knee mechanic ones, and so these and the quality of life measurements as well. And so then we can compare this directly using the same measurement tools to like a total knee replacement. And that was sort of the goals and thoughts behind this. So we're going to see here, I guess, can you see my cursor where so we looked at degrees range of motion. This is knee flexion. And you can see that on average before the surgery, average is about 140, and we see that it improved about 10 degrees on average in the left and right legs, and then the alignment, or I'll show you how we measured this in the next slide, but the alignment, so whether the knee is a hinge joint and it should be straight, and if it's off, an angulation. So most women with lipedema have a valgus angulation or kind of knock kneed, and that improvement of that was about 3 degrees in both the left and right leg. And that again is going to put less stress on the knee joint and the hip joint. And then we looked at their gait, and prior to surgery, 80% had an abnormal gait, and after surgery, 80% had a normal gait. So that's a significant improvement. So this is how we measure those. We also measured a Q angle. This is the first is the measurement of the Q angle here, and then here is the measurement of knee flexion. So this is a lady with lipedema, and you can see here normal would be 140 degrees, and that'd be where this green arrow is. And the red arrow is where she is, and so that's a significant decrease in the range of motion of that knee. And this is how we measure the alignment of the knee. So, I mean, that makes all the difference. I mean, getting in and out of a motor car or a bathtub, you need a full 135 degrees of knee flexion. And as you saw, most lipedema ladies are well below that. And also just even like, running to catch a bus or whatever, if you have to, is going to be limited. And the 10 degrees that they on average improved, can make a huge difference. I mean, this is an NIH tool called Promise Mobility Score, and basically average normalized for the U.S. population would be 50, and so the average mobility was quite decreased by in our lipedema patients, but improved significantly after the surgery. And the retesting was done 8 weeks after the surgery. So about 16% of our patients increased their ability to walk at a normal speed by 16%. Also 16% ability to go up and down stairs without difficulty. And a 27% increase in the ability to run short distances. 12% ability to stand for an hour. And that now, Sherry touched on, we treat this comprehensively. Lipedema first of all, surgery doesn't cure lipedema, and it needs to be treated comprehensively, and that includes compression garments, but also what we call an anti-inflammatory diet that involves low refined carbs and low processed food. Lymphedema therapy for those who decongestive therapy for those who have also lymphedema, and quite a few of our patients have that. A home exercise program and weight loss if possible. Now these conservative, I've previously published a paper using the same. So all the patients that had the surgery all went through this conservative treatment prior to surgery, and are asked to continue it after surgery. But just looking at the conservative treatment, they saw a slight decrease in limb circumference and a reduction in pain. But it did not, just the conservative did not improve the mobility or knee mechanics, or the quality of life measurements that we looked at. So we did see a 12% decrease in pain, and And then we looked at this is the RAND SF36, and this is a very commonly used research tool to look at 8 domains of the quality of life, from your physical function to role limitations from physical or emotional, your overall energy, emotional well-being, social functioning, and general health. And so all of those statistically significantly improved um, uh, before, after the surgery. And again, we didn't see these kind of improvements in the quality of life from just the conservative. We did see a 12% increase in overall health, an 11% increase in ability to activities of daily living, 13% to ability to complete tasks, and an increase in ability, like 10% even when emotional limitations. We also looked at the lobules. So lobules are, as we all know, occur in lipedema, and they're usually seen in stage 3, which, and there's, everybody knows a lobule is like a mound of tissue that that juts out from where it should be. They commonly occur on the lateral thighs or knees. And so we looked at that, and we found that about 80% in our stage 3 people, 80% had thigh lobules, and after surgery, it was a small percentage, like 5%, and then that would be on the inner thighs, and same kind of thing on the lateral thighs, and then knee and arms. And I'm gonna show you a couple slides of the before and afters. This is the before at the bottom, and then after, and then you can see obviously the arm lobule is gone. And this is someone who had several surgeries on her legs, and that's the before and after. And here is an example of these knee lobules, and you can see, before and after, pretty significant change. So it can be argued, if since the lobules are key to the stage 3 versus stage 2, that they had regression of stage from the surgery. We can debate about what that means for them clinically. I'm sure we might have a question about that. Well, that's the highlights. And then I wanted to have lots of time for questions, and anything more I can help with, I'm happy to do. So do we have any questions?
Thank you very, very much, Dr. Wright. That was really informative. This is Sherry Fetzer, who's chair of Lipedema UK. I have a couple of questions. One is, how many operations did it take to get this sort of improvement for the average patient? Is there a
That's a great question.
fixed number, or do you have a program that you follow? I know you are a surgeon who operates in your own surgery. So what is the protocol, and what type of surgery do you offer your particular patients to get this fantastic improvement?
Well, so first of all, what a great question. And the answer, the answer is most people got the improvements in mobility and knee function with just one surgery on their thighs. Now, You don't get the full improvement in knee flexion until you do your calves as well, but that would be 2 surgeries. And then, some had as many as 5 surgeries, but that's, the measurements we were looking at as far as for the, the mobility, were, and the knee flexion. So they had a improvement with the one, more with a second surgery on their calves, and some had further improvements, but it was kind of stabilized. Like the arm surgery didn't help their overall mobility. It generally helped with the arm heaviness, but and so this is, I know this is controversial, but I also believe that lipedema also occurs in the abdomen and trunk, and I treat the abdomen trunk, and that would be a 4th or 5th surgery.
Okay.
That's.
Sorry, I'm going to keep asking questions, a few ones to just to check I really understand what you're saying. So you do, what sort of anesthetic do you use? And
Yeah. So
you
we
use a
so we
general,
use
I presume.
yeah, so we use tumescent anesthesia. It's very similar to what Dr. Rapprich uses. We don't use general anesthesia. We use tumescent, and so and then we might have give them a mild sedative as well. But yeah, that's what we do. And these are outpatient procedures. I use the tumescence, and then I use just a vibrating PAL kind of suction and with small blunt cannulas. And that's my surgical technique. Now we have a systematic way. So after 6 weeks after each surgery, we do a follow-up, and then we remeasure the mechanics and the gait and such like that. And so then we can see it stepwise. And so that's how we can tell you about, when we start to see the improvements and that sort of thing.
Okay. I was particularly struck by your slide where you showed somebody standing upright, and you said you had a measurement of standing for 1 hour and how that improved, because that has a tremendous impact on people's jobs and career prospects. And it's really interesting to me that is the standard measurement, whether you can stand or not for an hour, which is just a basic human function, surely, to have that sort of mobility. And I also.
Yeah, for sure. And I mean, that's, so we see, here in the Midwest, we see, people.
But their whole front seem to straighten up in that photograph somehow.
Yes, yeah. So I'm sorry.
Yeah, sorry. I just thought that was quite striking, that wasn't necessarily gait, but it just was how you perform everyday tasks and how comfortable you are doing them.
Right. Yeah. Because that's really, that's many of our patients struggle with that from their lipedema. And so, yeah, I think we want to, it seems like a simple thing, but again, so many women struggle with that, and I think it's important to show that to really demonstrate the power of the surgery.
No, it's really, really impressive. Tess, do you have any questions you'd like to ask from the chat?
Yeah, there's quite a few in here. I'm scribbling them all down as I go. They're coming in thick and fast. The first one was from Maxine. She's struggling to lose weight. She wants to have surgery. She said, is it better to lose the weight before surgery, or is it possible to have the surgery and then continue to lose weight?
Well, I think it's best to lose the weight first, if you can. I mean, obviously, you're going to have additional weight loss as you improve your mobility, but the amount of tissue that has to be removed and the risk of complications is going to be higher the higher your weight. So I mean, I often will. So we will use put them on this low refined carb diet, and we will refer people for those GLP agonists and even bariatric surgery. Now there's sometimes when people they've even had bariatric surgery and we will operate on them, but I do think that it's really best if at all possible to have the weight loss first.
Thank you. The next one was from Catherine. She said, is it possible for you to outline the age ranges and numbers of patients in the analysis that you spoke about?
So, yeah, that's a great question. Thank you, Catherine. And it was 194 patients that were in the study, a total of 500 surgeries. The age range was from early 20s to 70 something, mid 70s was the age range. So quite a wide range of ages. So age range, and were anything else I'm missing on Catherine's question?
No, age ranges and numbers of people was what she asked.
Yeah, so 194, which is a pretty good sized study. I mean, honestly, that's much larger than previous published studies on lipedema. And as far as it encompasses a total of over 500 surgeries.
Thank you. The next one's from Ruth. She said, how can I tell if knee pain is osteoarthritis or if it's my lipedema that's causing it?
Right. So this is a great question. And we struggle with this, but so the knee is sits on the patella floats in the tissue. The tendons float in the subcutaneous tissue are right next to and so the patellar so pain from that can really be aggravated from that from the lipedema. It also puts a stress on the mechanics, but so it really takes a careful exam. So obviously, if it's in the joint space, and this is just an orthopedic exam, I mean, I almost want to like show you my knee and show you where, if you have tenderness right at the joint space, it's from the joint and not from lipedema. And if it's just sort of a generalized pain over the top of the knee, it's more likely from lipedema. But again, it's hard to tease out. That's not an absolute, but yeah. And of course, knee pain if you have knee pain in those lobules that's lipedema too.
Thank you. That explains quite a lot. Fiona is saying that she's been refused a knee replacement because of the lipedema around her knees. She does have fixed flexion, so is it really too late for her now anyway?
No.
It's a question I would have asked myself as well. So.
Yeah, that's a great question. So I think that so again, this is why so there's so many benefits from treating the lipedema, including mobility. But one of the things is it also, when you reduce that lipedema tissue, your chances of having wound not the wound from the knee surgery not heal. And that's one of the concerns. So the biggest concerns the orthopedic doctors are going to have is healing of the surgical scar, complications like infection, and then the other thing is called arthrofibrosis, where you do a knee surgery and it stiffens, and that is more if you have limited. So all this lipedema tissue, again, think of this hinge. I'm not sure if you can, but basically here's your hinge. Well, if you can't, if it can only go here and can't, you can't bend all the way in. Well, you're going to have your risk for a stiffened arthrofibrotic knee are greater. So if you have the lipedema reduction surgery and you have that tuned up and you heal from that, then the chances of having a stiff knee or having a wound failure because you have so much tissue there that is going to be less. And so I mean, I routinely, the orthopedics doctors, I have some that send me patients, and that's why I think treating the lipedema first, also treating the lipedema early to prevent the extra stresses that occurs on the knee is also important. But even if it has gone to the point where you need a knee surgery, I think there's some advantages to doing the lipedema reduction surgery and then having the knee replacement.
Next question is around lipedema in the abdomen. How common have you found that to be?
So, so Dr. Herbst, Karen Herbst, has done a couple papers, and we found that about 60% of women with lipedema also have it in their abdomen and trunk. Yeah.
That's quite a lot. Yeah, my personal experience too. The next question is from Gail. What is the maximum liters that you will remove from limbs?
Well, I don't have a max. I mean, there's no, I base that on individual, the individual assessment of the patient. I have removed up to 13 liters in a single surgery. But my average is right around 5 liters. And so it depends on the area that I'm treating. And so a larger stage 3 lady with, from the hips and buttocks and thighs, I might get, routinely get 8, 10, even 12 liters off. But in a smaller person, and on a different area like the arms or the lower leg, I might only get 3 or 4 liters off. So and there are some very small ladies with lipedema but still have symptoms that will have 1 or 2. So yeah.
Liz asks, should liposuction be used at an earlier stage, ideally?
Yeah, I think so. I think, once it's if it's affecting gait, mobility, quality of life, it needs to be done as soon as possible.
Maxine picked on something that you mentioned in the presentation about diet, and she said, is there a document that you could share about the diet you advise your patients to follow pre-surgery?
Yeah. So this, I mean, the best, so Dr. Herbst did this her RAD book, and then so some people, so I give a more general, and I will share it's basically like what we recommend for someone who has diabetes, in that low refined carbs, eating as much whole, less processed vegetables and healthy fat, and then, but there are specific like there's specific ketogenic diets and there's specific anti-inflammatory diets, like the one Dr. Herbst and Eicher published on. And then so I just generally go review the diabetic low refined carbs, but some, again, there's some people get better benefit from a pure ketogenic diet, and if it works for them, then I'm in favor of that.
Another question there from Tina. If you have varicose veins, should they be removed before surgery?
So yeah, often, so if they're large varicose veins, that's going to increase your risk of bleeding and complications. A few, a few small varicose veins probably don't need to be treated. And so, yeah.
Hi, can I interrupt you, Dr. Wright,
Yep.
and here? I think what we'll do is we'll end the YouTube session here and go back to just our Lipedema UK members. So we
Great.
will continue. If you've joined us on our Zoom link, we're going to continue with this call with Dr. Wright and asking him questions. But if you're live on YouTube, thank you very, very much for joining us. I hope you've enjoyed this presentation from Dr. Wright about all the benefits of lipedema reduction surgery, especially on your knees, gait, and so many things that are important in everyday life. So a huge thank you from us all at Lipedema UK for doing this, Dr. Wright. But do stick with us because we will be continuing to question you on the Zoom link. Thank you very much, everybody.